All right. Thank you so much for joining me today. My name is Wendy Farmer, and I'm the crisis lead for Beacon Health Options, and actually also a proud AAS member for many years. So I am very excited today to have with me Colleen Creighton, the CEO of the American Association of Suicidology, and Dr. Jonathan Singer, who is the president of the board of directors. And for those of you who don't know, the American Association of Suicidology is the world's largest membership-based organization that's really focused on suicide prevention. They promote research and prevention activities, public awareness programs, public education, and training for professionals and volunteers alike. Colleen joined AAS in 2017 as the CEO. Previously, she served as the executive director for the Alliance for Consumer Education, a nonprofit foundation dedicated to the safe and responsible use of consumer household products. She has a long history of working in education and educating the public on important topics, and certainly suicide could not be more important. Dr. Jonathan Singer is an associate professor for social work at Loyola University Chicago. His clinical and research interests include family-based interventions for suicidal and cyberbullied youth, service access and service utilization, and the use of technology in education and treatment. He's an author and frequent online contributor and the founder and host of the award-winning Social Work podcast. So thank you so much. I hope I got some of that right. Thank you so much for joining me today.
Yeah, no, it's a pleasure. Thank you so much for having us.
Agreed.
I'm excited.
Thank you.
So I've got a couple of questions for you, maybe we'll get to some broader ones at the end, but I wanted to kind of focus on some of the things that are really top of mind right now for people first. So we know since the beginning of the COVID pandemic, we've heard reports that crisis lines and text lines have received more and more contacts from people, with anxiety, depression, and stress, certainly related to everything going on. What has been the specific impact of COVID on suicide, or do we know?
So there are different reports. First of all, let's talk about suicide deaths specifically. One of the biggest problems that we have in the United States is that we don't have real-time data on suicidal events nationally. Right? Any given locality, you might be able to call the local school district, or if you know the medical examiner's office, and get that. Or if you're a reporter, you do a FOIA and you can get access. But there's no national level data that is happening right now that we have access to. What we do know is that there's reports from, say, Denver that suicide is down 40%. But we know that in Chicago, suicide among Black men is up compared to last year. We also just had a CDC report that showed that 1 in 4 folks 18 to 24 had thoughts of suicide in the last 30 days. And that's up dramatically from the same time last year. So we have different information. When we look at the crisis lines, we see that crisis calls are up, but not necessarily calls to suicide prevention lifelines, or that the things that people are talking about when they're in crisis are not necessarily suicidal crises. And so it really speaks to this idea that we need better data. We need better information in real time. If I know how many people were diagnosed with COVID in Louisiana yesterday, it makes no sense that I need to quote stats from 2018 as being the most recent available in suicide deaths.
No, I mean, I couldn't agree more. Unfortunately, from our position, by the time we can get a plan of action, it's already been 1.5 to 2 years later. And so we really can't, we'd love the tracking to be able to kind of see things before they happen and be able to work with that community. There's a lot of piecemeal things being done. There's programs in schools, like Jonathan said, in like certain health departments in certain states. We need a much more coordinated national strategy on this to be able to track and then to get programs and to get help to the people that need it.
Sounds like a great thing for AAS to help with. That's exciting.
We're working on it.
Exciting. So, Jonathan, you mentioned that CDC report, and certainly that's alarming. So, 20% or 25% of youth 18 to 24 were reporting suicidal thoughts in the last month. Are we kind of on the brink of a crisis related to youth? I mean, is there something specific about this population that makes them more vulnerable right now?
Well, let's talk about some of the assumptions that we make when we see stats like that. One, we make assumptions that there is a linear relationship between ideation, attempt, and death, and there's not. So if we look at the stats from from youth under age 18, we see that there's been a rise in thoughts of suicide and attempts with medical attention, but not deaths. Right. And so it's possible that we could have this significant rise in short-term suicidal ideation that doesn't convert into suicide attempts or suicide deaths. Now, if it did, if we saw a bump or an increase of 50 or 100% in suicide deaths, we would be looking at, I don't know, 100,000 youth that age die by suicide in the next year or so. We don't have that information. So that's just an assumption that I think is really important for people to be clear on, that there's not this linear relationship. It doesn't mean it's not important. Because one of the things that I think it's speaking to is something that is already a developmentally appropriate stressor, which is, what am I going to do with my life? Right? 18 to 24, either you're just starting college, or you decided not to go to college, or you couldn't get into college, or you're graduating and you're trying to get your first job or whatever. All of that is off the table right now, right? You have kids that didn't have graduation from high school. They're not having their first year of college, stressed out and anxious. You have kids that were college students who are graduating into one of the sort of most solidly sort of robust economies in decades. And they actually graduated into the worst economy in almost 100 years. And that is a shock to the system. And so I think that having understanding that youth are experiencing anxiety and depression, that they are generally stressed out about the future, is not pathological. It's actually a realistic reaction to an uncertain time. And so I think it's really important also for people to know that the CDC put out a report a couple of years ago that indicated that lots of folks had suicidal attempts and died by suicide who did not have a pre-existing mental health condition, that were not clearly, meeting criteria for a DSM diagnosis or things like that. And this really flips on its head a message that the American Association of Suicidology and other suicidologists have been promoting for years. So we need to take responsibility, which is that there is a direct relationship between what we call mental illness and suicide. And that does not appear to fit the data. And so let's think about these kids having a normal reaction to an abnormal time, understandable developmental stressors, and they're thinking about having thoughts of suicide. It doesn't mean they're going to kill themselves, but it also means that we do not ignore this as a really serious issue.
That's great. I mean, that's a great thing for people to understand, that it's not a linear relationship. Also related to kind of the times that we're in right now. We know that Black, Indigenous, people of color are being disproportionately affected by this pandemic. Is that also the case for suicide? And if so, why and what can we do?
Well, let me just say real quick, and then I'll pass it off to Colleen. Again, the data that I'm familiar with from the pandemic and race really revolves around Chicago. And Chicago's not a small place. I mean, so we're talking about, there are like 8 or 9 million people in the metro area. It's third largest city in the United States. And we did see an increase in suicide deaths amongst Black Chicagoans. It doesn't mean, though, that is a national trend. And if we think about the pandemic, we know that Black and brown folks are a larger percentage of essential workers, frontline workers, doing the kinds of jobs, being in situations where they are unable to keep themselves safe in terms of the CDC guidelines and protected. Everything from like, more reliant on public transportation and in more crowded housing situations because of the historical legacy of redlining and all sorts of other racial injustices that sort of make up the United States. And so it is possible that there is an effect or relationship between this increase in suicide deaths in the Black community in Chicago and what we're seeing with the pandemic, but we can't say that for sure because we only have this one data point.
And I also think if you look back at the history of the field, one of the things we have not been very good at is being inclusive. So Congressional Black Caucus put out a report that raised some eyebrows last December, and it really showed an uptick in young male Black suicide. And then because it was released in December, it didn't get really the media exposure that normally a report of that size would. And then if you dial it back and you look at all these other populations that are affected by suicide, where their numbers are like, where anywhere else that number would shock public and get more media attention, it's just been marginalized. And I think what we're doing, especially at AAS, is we've said we need to start looking at this issue from a number of different lenses, not just from here's the number of people, more than 48,000 lives are lost to suicide each year. So we have those numbers, but we really need to do a better job at including all the divergent populations, all the different marginalized communities that haven't felt welcome in the community. And I think we can't just look at this as it's an individual life, but we really have to work with a lot of the communities too, and saying, whether it's Chicago, whether it's all around the country, your life matters, your voice matters. We want to include you, and we want to get you the help you need.
And that was definitely clear, at the recent conference, which I really appreciated. So, and definitely was front and center. So thank you to both of you for all of your work on that. When it comes to suicide, we all know that every suicide, impacts many people, loved ones, family members, coworkers. It really has an impact on everyone. I think one group of people that are often forgotten are clinicians who have cared for people who have died by suicide. I've been a clinician for many years, and unfortunately have had that experience. But what can we do to support clinicians? What's the impact on them, and what can we do to support them?
One of the things that we have is we have the loss division at AAS, and there is people are active in developing clinician loss training and making sure that clinician loss survivors are included, feel welcome, and know that there's a place for them. Now, there's oftentimes a tension between loss survivors who are family members and clinicians, because there can be anger or resentment from the family member toward the clinician, especially if somebody was under care when they died. And so these are things that aren't just sort of simple, like, oh, we just throw a bunch of people together and it's gonna be all good. Like, we're really actively thinking about this. What does it look like? What's helpful? Where do we have people together? Where do we have people separate? And I think that, with the rising rates of suicide, and also what we've seen in the rising rates of suicidal ideation and attempt, that's really where we need to talk to clinicians and provide training about addressing suicide risk with folks who don't die from suicide. We know that clinicians are less likely, if they have any choice in it, and if you work for a publicly funded agency, you often don't, but if you have any choice in who your clients are, we know that clinicians are much less likely to take somebody who's been actively suicidal in the past. And this is an educational opportunity for the field to say, look, it's a professional expectation that you provide quality services to somebody with a history of suicide ideation and attempt. Because if the clinicians aren't doing it, you can be sure that we are setting a bad example for every other part of somebody's life, workplace, faith communities, all sorts of other places where people need to have support. And if you can't find it from the mental health professionals, then that's a real strong statement right there that maybe your life doesn't matter. And that is not at all the message that we want to share.
And the task force that Jonathan mentioned, actually, they just launched their new website too. Well, it's the start of a website to start getting the information out there. It's cliniciansurvivor.org. And so Vanessa and Nina Guten, what they do is they pull together, they've been holding weekly calls and monthly calls with their group to address any issues that come up, to kind of really get a feel for what clinicians need too. We know what they need from one perspective, but what do they need that maybe we don't know about? And so what they've done is they're developing a training that'll launch later this year for really having the opportunity for clinicians to kind of see that others are going through this as well. And then, we'll offer the training to clinicians as they need to. So as part of that, the task force is first, and then they're going to start rolling out a number of different resources from later this year to next year.
That's wonderful. I mean, that's just another example of how AAS is working so hard to help everyone, all comers. That's really wonderful to hear. That's something I really appreciate. And every time I see it posted, I know Chris Maxwell puts it out all the time. Suicide prevention is, everyone's business. And, that is so very true. So if it's everyone's business, how can payers be involved in preventing suicide? What are your thoughts on that? How can we all be involved?
Colleen, do you want to start or do you want me to start?
Go for it.
Okay. So in the United States, we have a patchwork quilt of how services are funded, right? We have payers that reimburse providers at different rates. We have different services that are reimbursed. We have legislation for Medicaid that says that two providers can provide the exact same services but get reimbursed different rates based on their licensure or degree. And what this does is it makes services incredibly complicated for the consumer to understand. And it makes it really complicated for organizations to manage. And so one of the things that I think is really important for payers to understand is that when you're working with somebody in a suicidal crisis, the clinician or the provider is doing a bunch of work that doesn't fall underneath billable categories. Right? So you do a 2-hour assessment and you can bill for that. And then, well, what about the 10 or 15 phone calls that you make that might last for 5 or 10 minutes? What about the check-in phone support, right? If you're doing management of a suicidal crisis and you see somebody for an hour or two, yes, you give CPT codes for that. But then what if you are doing good clinical care, the things that we consider best practices, which means that you're actually calling, or these days you're texting, right? To say, hey, just wanted to let you know I'm thinking about you. Caring letters, caring texts, right? It's that same idea. What's the reimbursement code for a caring text, right? There isn't. And since we have providers who are dependent upon payers to cover their salary, to cover the costs of their phone lines, their offices, we really need payers to have a much better understanding of all of the work that's involved in managing a suicidal crisis and how it doesn't fit into the boxes that we've set up for quote unquote traditional therapy services.
So looking at that whole continuum of what it takes and, best practices in serving someone in crisis and making sure that all of those pieces that there's a way to be reimbursed for that whole piece, every piece of that puzzle.
Yeah, absolutely. I mean, like if you have crisis services that are getting reimbursed per service, services end up looking very different than if they are getting reimbursed for the the entire period of time that they're providing the services, right? Yeah, I could go into lots of details about crisis services, but I think the same idea applies, and it's really a bad place for payers or insurance companies to save money. It's really like one of those places where it's not a particularly ethical or practical way of trying to save a buck.
Yeah, well, it's about providing the best care, that takes care of the most people, and that's good business, right? And I think we all agree on that. Absolutely.
It is good business. And the last thing I'll say is that the nature of crisis and the nature of suicidal crises, and when you're working with somebody who's been suicidal, like they can go a week or two where things seem to be going okay, and then the crisis happens, right? There's something that intensifies. It moves from, urgent to emergent, right? The provider, if the provider is not getting funded for those times where things are sort of slower, then that that demonstrates a lack of understanding about the cyclical nature of managing a suicidal crisis. And so I know that I've been in work situations where management has said, okay, you have to do something else. You can't just be sitting around waiting. And I'm like, good crisis services are available when people need them, because that's what we're doing. That's what we, and so
being available, right?
We're being available. And so payers have to understand that you're paying for people to be available. And that means not piling on a bunch of extra work in order to, quote unquote, save a buck over here, right? Because we have these other people doing it.
Yeah, totally makes sense. I appreciate that so much. What, just in the few minutes that we have left, what are the kind of general trends in, research or prevention that you really think that we all should be aware of right now?
And I know, I think there's a number. I know for us, at least, making sure all these different voices are included, making sure that we're not looking at everything from just kind of a uni lens and just saying blanket, this is how it should go. I know for AAS, one of the things that we're doing is really reaching out, instead of being a top down, here's what we need to do, pushing it out to every community. We're doing a lot more listening on the ground and kind of getting an understanding of where the gaps are at the ground level that need to be filled. And so it's not just we've developed a strategy and this is going to be equitably applied to every single person the same way. We're understanding that there is a difference in utilization that we're going to need to address.
Yeah, and this plays out in terms of the way that that our research division chair is talking with researchers about saying, research is essentially like, a methodical way of answering some questions, but what are the questions you're trying to answer? Who are those answers important to? And this is where the strength of AAS comes in, because it is the only place where you have the lost survivor, the person whose spouse was, active military for 20 years and died by suicide, who can talk to the researcher who's doing research on military suicides, right? So in terms of the trends that we're seeing in research, some of them have to do with technology. There's a research technique called ecological momentary assessment, which is really powerful, and it's getting real-time data about the experiences of folks who are suicidal. And it's challenging a lot of our notions about what it means to be suicidal. And what I was saying just a few minutes ago about the sort of the cyclical nature of a suicidal crisis, EMA has suggested that within a single 24-hour period, somebody can go from really looking like no risk at all to extreme risk, a matter of hours. And this is actually from actual real-time data, not somebody, telling a story a week or two after the fact. This is happening right now. Some of the other things that's happening is that we've seen analyses of the Garrett Lee Smith data. And so we have, for the first time ever, a 2015 paper and then a 2019 or 2020 follow-up from David Goldston's group out of UNC, saying that comprehensive suicide prevention programming in communities, college and tribal nations saves lives. That when youth are in communities where this happens, it reduces the youth suicide rate by between 1 to 3 per 100,000. Which is amazing, because right now, 2018 stats, we're looking at about 10.2 per 100,000. You decrease that to 9 or 7, huge. It is enormous. right?
Mm-hmm.
And we know that this works because of the data. And so these are some of the trends that we're seeing in research that I think are incredibly powerful for what we do and how we do it.
But I also think amplifying the research that's out there too. For far too long, we're finding a lot of it was just siloed and it just was never shared. And so one of our committee directors, the Firearms and Suicide Committee, said he actually funded a scholarship at AAS specifically calling out research for the sake of working towards a public good. And ensuring that it's not just to get a name out there or just a piece published, but it's actually aiming to do some service and making a dent and kind of having an impact. So that's one aspect. The other thing, you mentioned Chris earlier. Chris and I actually went back to our journal publishers and asked for, it was acceptance, purpose, gaming, and connection, to kind of take a look at what research is out there on more of the positive aspects, specifically because the notion about COVID and everything we're hearing is so negative. What's on the flip side? What's out there saying, like, where's the good? Where's the connectivity? What's, where can we grow from what we're learning now from that aspect, from a more positive aspect? So that's one of the aspects we're starting to dig into this week, starting, as a matter of fact.
That's exciting, and, fills us with a lot of hope that there's such great things going on. Before we go, Jonathan, I just want to mention your shirt.
Yes.
And I'm really glad that you wore it. Best thing that we can do to take care of people, right? Is just be willing to ask the question. So, really, really happy to see that.
Yeah, and this shirt is one of the things that, AAS campaign. You okay? Friends ask. Right? It's this idea. It's a simple reminder, and it's not that it's the solution or that asking somebody is always going to be the answer, but it's a reminder, because so often we hesitate. And when we hesitate because we're scared, it means that we're pushing right up against genuine connection. And sometimes that's scary for us, because if we genuinely connect, we might actually hear something that's hurtful or painful. And that's a scary thing. But friends asking and being like, hey, are you okay? Like, simple, but profound. So absolutely. Always happy to wear this t-shirt.
Well, thank you both very, very much. I so appreciate your time. And we got a lot packed into 30 minutes. So, so appreciate it. And thank you for everything that you do and continue to do.
Thanks, Wendy. It's a pleasure talking. Yeah.